Okay, so today I'm going to take you through a series of short videos um, focused completely on this one paper from the Physical Therapy Journal. The paper is related to the hypothesis-oriented algorithm for clinicians, or HOAC 2. This is one of a few models that we emphasize throughout the curriculum. This particular paper provides a great framework that we will refer back to throughout the curriculum. So we're starting here in PT Exam 1 to provide an introduction, and we will slowly tease out the entire model as we move through PT Exam 2, then PT Interventions, then you go off to clinic and you come back and we continue to apply this approach. Now, it's going to be important for you early on in these first few weeks to spend some time with this paper. As I take you through this paper today, I'm going to focus on particular graphics and specifically part 1. There are two parts to this model, but I'm going to focus on part 1. So as you scan through the paper here, there's a fair bit of text, but they really do a great job in terms of explaining the basics of the model, the basis behind it, where it came from, and why it's important for PT practice. So I really encourage you to spend some time and take some notes related to what's being described here. You will hear both Dr. Washmuth, Dr. Bowens, and others throughout the semester and subsequent semesters talk about this model, refer to some of the steps within this model. So as we scan through, I'm going to bring you to the main part that we're going to talk about here, which is part 1 of the model. There you go. So there's HOAC part 1, and then as we scan through, we get to part 2. Now, part 2 is a little bit more advanced in terms of critical thinking and clinical decision making, creating your own evidence for patient care, and you're not going to quite get there this semester. So we're going to focus our attention on part 1. Now, the main reason that we utilize this model is because it emphasizes a patient-centered approach to care. It's very easy as students and as clinicians in general to get caught up in what we're looking for, what we see, what systems we might think are problematic, and lose sight of what is most important to the patient. And that's one of the main reasons why we highlight this model, is because it emphasizes putting the patient first. On top of that, what it also does for us, which we think is very important, not only does it put the patient first, but it really categorizes for us, how we should look at patient problems, how those problems may or may not relate to the injury or health condition that a person has, the impairments that they have, or the functional problems that they have, or the disability that they have. And we'll go through those terms here to a certain extent, and you will hear those terms throughout the semester and subsequent semesters. Okay? So what we're going to do now is I'm going to take you through this first page here and just kind of go through these boxes and talk through them. And then we'll take a little break and go back to the second page of part 1. So let's focus in here a little bit. Let's start at the very top. So the first thing you're going to do, as I think would make sense to all of you as a physical therapist, is you're going to have some initial data. That data will come from a referral from a physician, perhaps from another healthcare practitioner, perhaps from a colleague, a PT. you'll have some sort of medical record. It might be a chart within a hospital. It could be a health history questionnaire that you have them fill out in a patient outpatient setting. And then perhaps most important, I would argue, we'll say equally important to the referral and the medical record is your ability to observe and see what's going on with that patient before you begin any formal evaluation. So the most common example of this would be if you're the one that goes and meets the patient in a waiting room, you're actually beginning to collect initial data as they walk back with you to your treatment room, your exam room. And so that's a part of collecting initial data. And then the last part is the interview, where you begin to ask questions, trying to gather information about what is going on with that patient. Okay, so let's just review. So the first box here is collecting initial data. That's the first thing you do in a patient-centered approach, according to this model. And there's 4 components. 4. The referral, the medical record, your observation, and then your interview of the patient. Okay. Now, as we move through the model, moving away from collecting initial data, down from that black rectangle, if you will, to the next step, you see that the next thing we do after collecting initial data is to generate a patient identified problems list, PIPs. Now this is probably what's most unique or distinct or I'd say unique or distinct in comparison to other models, is that it really emphasizes what's important to the patient first off. So let's go back to the collect initial data in the interview. And in the interview, you're going to start to ask some questions. Now, knowing that you have to generate a patient-identified problem list, probably the most common approach you would take to generating that list is to ask a very open-ended question. Why don't you tell me what's going on? What are you having difficulty with? Allow the patient to describe in their own terms why they are there to see you that day. That's in comparison to an approach whereby perhaps you look at the referral or the medical record and you notice that they have a diagnosed injury. And you initiate the exam by saying, I see that you've injured your knee. You have a left knee sprain and a hamstring strain. Let's look at that. In that approach, you are dictating and determining exactly what's going to be done without even considering what's most important to the patient. So step 2 is PIP list, and let's just look at the text within that box. So when we make or determine or list out the PIPs, they're at the level of functional limitations and disabilities. And I'll talk about that in a moment. These problems, and I stated this a moment ago, are described, at least at this point, in patient-oriented terms only. We want to reflect what's important to the patient in terms of what they can and cannot do. This may not be the way that you measure things. That may not be the most objective way to capture what's going on. But we want to see and hear what's most important to the patient first. Now let's go in that first sentence there in that box, the PIP box. I just mentioned that it's functional limitations and disabilities. What is that? Well, we have a couple different models that we need to consider, and I'm just going to focus, since we're using the terms functional limitations and disabilities, I'll focus on the other 2 terms of this disablement model, which are pathology, impairments, then functional limitations and disabilities. Specific to these 2 terms, here are some examples. A functional limitation is the inability to walk, the inability to get out of a chair, the inability to complete a particular task, as opposed to an impairment might be a loss of range of motion, weakness, pain. Those would be impairments. Disability is a person's inability to complete their social and or professional or personal roles within society. So, for example, if we wanted to connect functional limitations and disability, if we have the inability to walk, we may be disabled as well because we can no longer work, or we can't work at this point in time because we can't walk, and our job, our occupation requires walking. So if we go back to your role as a PT and being patient-centered, when you start your interview, you say, Mrs. Jones, why don't you tell me what's going on? Why are you here to see me today? We would expect to hear something related to what they are having problems with. What can't they do? Okay. So Mrs. Jones might say, well, I'm really having problems walking, or I'm losing my balance. Okay, why don't you tell me more about that? And they might proceed to tell you more. We want to list their problems in terms of what they can't do and how it affects them and their roles in society, versus going in there and listing problems that relate specifically to pain, weakness, loss of range of motion, loss of sensation. Okay, we will get to those. Those are important. Okay, but we need to first look at things from a functional standpoint and from a disability standpoint. Okay, so let's review first two boxes, and then actually I think it would be a good place to break for this first component of the video, and then we'll pick up with formulating examination strategy. Collect initial data, 4 components. As you're collecting initial data, you start to generate a PIP list. You are looking for the patient's perspective and looking at it at the level of functional limitations and disabilities, their problems. I can't walk, I can't sit, I can't do my job, I can't go to school. Those are all examples of patient-identified problems that if a patient has an opportunity to tell you about it, they will. So problems are functional limitations and disabilities. Problems are not, I repeat, not impairments. And I'll give you a good example of this and talk about this example each and every year. I mentioned before that pain is an impairment. If we took the entire class and we polled the class in terms of a certain amount of pain that they were having, that pain would impact certain people differently. Some of you would be incapacitated by a certain level of pain. Couldn't sleep, couldn't get out of bed, couldn't do anything. Some may only be affected at a certain time of the day. And some, whether right or wrong, would work through and push through the pain no matter what. So in the end, what you're most interested in is what is the patient's perspective and what problems are they experiencing. It's not that you still shouldn't address the pain, but you need to understand how it's impacting them at the functional level. You addressing pain and figuring out how to measure it and then how to treat it comes later on. It's not how you want to categorize what's most important to the patient. If a patient came to you and said, well, I'm having back pain, the next obvious question, well, tell me how that's impacting you. It'd be rare, but I would question it if someone said, well, I'm having really extreme back pain. It's 8 out of 10, and you ask them how it's affecting you. They say, oh, it has no effect whatsoever. I'm fine. I could do everything. No problem. That wouldn't make any sense. The reality is most are going to say, well, I can't do this, or I had to adjust this. Then you're starting to get at the patient-identified problems. Okay, so we're going to stop here on this first one. We've covered these 2 components of the HOAC model, collecting initial data and generating a PIP list. Next video you look at will be getting into our physical exam related to or off of these patient-identified problems. Okay, let's continue here. We're going to, sorry about that. We're going to move on from the PIP list and talk about our exam. So the next box there, formulate examination strategy. Now your strategy, as it says here, is based on an initial set of hypotheses generated from available data and the nature of patient-identified problems. So as we move through these next few steps, starting with formulating examination strategy, one of the things that's key to this model and why we emphasize it is everything you do in terms of the steps of your exam should fall out of what's most important to the patient. So the patient says that my main problem is I can't walk. You shouldn't be going through aspects of an exam or formulating an exam strategy that are not related to problems in walking. That's not a patient-centered approach. Okay? So you formulate a strategy, it comes from the patient-identified problems, and you begin your physical exam. Now you are going to learn a lot of aspects of physical exam throughout PT Exam 1 and PT Exam 2. You're going to hear in the first couple weeks about the patient-client management model, PT Exam, the components of the exam, systems review, evaluation of data, giving meaning to it. You're going to learn about diagnosis, prognosis, plan of care, interventions, and outcomes. Okay, that all fits into this, and I'll have later postings or videos that will tie together those models and what you're learning in PT Exam 1 to this HOAC model. Okay, but just know that you right now, in terms of patient-client management model, you're still in the PT exam part. Okay, so you're beginning to conduct a physical exam, right? And as you're doing so, you're getting data, let's say like you're going to learn about how to assess muscle strength, joint integrity. Okay? And as you're doing that, you are beginning to give meaning to data. You're beginning to develop hypotheses as to why you think they're having the problems that they are. This is why I think they can't walk. They said they can't walk or they're having problems walking. As I ask more questions and as I begin to look at the strength and range of motion in their legs, this all starts to tie together. So you start to develop some hypotheses. Okay, so this middle box right here has all this bold letter. I'm putting a cursor on. That captures a lot of what you would be doing. Okay, it's not a simple process. You'll learn more about it, but it's essentially going through the examination process and beginning to evaluate your data. Right? Now, as you move through that, one of the things that you're going to do, or that should occur naturally, is you will start to identify problems that the patient is not aware of. For example, they come in and you start talking, they start talking about problems in walking. I can't walk. Okay? So you start to conduct your exam, you're doing various tests and measures, and you're trying to give meaning to data as to why you think they're not able to walk. Well, come to find out, it's not walking is a problem, but what you identify as the main problem is balance. They don't even recognize that they're having a balance problem. They can't sit or stand appropriately. That's an example of a non-patient identified problem. That is a problem, level of function or disability, that is identified by someone else outside of the patient. The other common example that you will experience is that the patient might say, I'm having a problem with this, or this is a problem, or that is a problem. And then significant other, spouse or child, or whoever, pulls you aside and says, well, let me tell you what else is going on. They're having difficulty with this, this, and this. Okay. That's a non-patient identified problem. It's significant, it's important, but you notice it doesn't come before the PIPs. Put the patient first. But we can't ignore the fact that if you, another healthcare practitioner, a family member, neighbor, friend, whomever, picks up something related to problems, that they should be paid attention to. Okay? So let's review where we're at. I'm going to make this a little smaller so we can see everything. All right. So we collect our initial data. We start to listen. We listen to the patient, try and determine what's going on. What are they having problems with? What can't they do? Why are they there? And off that problem list, we start to develop an examination strategy, what data we're going to collect, what additional questions we're going to ask. We start to refine our hypotheses. This is what we think is going on based on what we're collecting. And at the same time, we're going to begin to make a list of other problems at the level of function and disability that the patient didn't identify, but we're identifying, or someone else identified. So our problem list, as we move through these first 5 boxes, is starting to grow. Okay? All right. So that's the first 5 boxes. Now, we get to a point where we need to begin to figure out more formally, why are they having these problems? Whether they identified them or someone else identified them, why are they occurring? Up till now, we've been talking about 2 aspects of the patient-client management model. The PT exam, and then giving meaning to the data, which is the evaluation portion. Now, as we get to these 2 boxes that you see here side by side, that fall under existing problems and anticipated problems, we're now talking about a PT diagnosis. So what you're going to do as a physical therapist within the process of managing patients is you're going to come up with a PT diagnosis. Now, what the HOAC model does, which I think is good and important to emphasize, especially as you're learning about managing and working with patients, is they create 2 different types of hypotheses. One is based on existing problems, as you see there to the box to the left, and the other are problems, anticipated problems, problems that are not there right now, but you believe the patient is at risk for in the future. Okay? So if we go back up to our 2 lists, we had a PIP list, okay, you see it there, and then we have an NPIP list. Now, within that list, it's not to say that the patient might identify, the thing they say is, well, I'm not really having any problems right now, but I'm really afraid that this pain that I'm having is going to cause me to lose my job. I've been slow at work, I've been unproductive, my boss has said something, that's an example of disability. I'm really afraid I'm going to lose my job. So the patient is actually identifying an anticipated problem. And you would identify a rationale. And we'll talk about that more specifically. The example we were going with initially was the person can't walk. And you confirm that. You see that they're having difficulty walking. That's a problem that's existing right now. Right? So for existing problems, whether stemming from the patient, PIP, or someone else, NPIP, the existing problems are connected to a hypothesis. Now, this is very important, and I'll say it, and you'll see some graphics pop up related to it. A hypothesis, a PT diagnosis, is always, at the very least, containing 2 components. So please remember this. As you move through the curriculum, at the very least, there might be additional, but at the very least, it contains these 2 components. The causal relationship between impairments and function. The connection between impairments and function represents your PT diagnosis, which, in the context of what we're looking at here, the HOAC model, is what they're calling a hypothesis. So as you look at the text there in the box, it says the level of impairment thought to be causing a problem. Now remember, problems, according to the HOAC model, are at the level of functional limitations and disability. So a hypothesis is connecting impairments to function. Okay. Now you notice the next sentence in this box. Sometimes hypotheses may be the identification of pathological processes causing impairments, functional limitations, or disabilities. Okay. You will learn later in the curriculum, I shouldn't say throughout the curriculum, but later in the curriculum, some examples in certain courses where there are multiple levels of assessment, or the PT is drawing causal relations between health conditions or pathological processes, impairments, and functional limitations. Okay. But just to restate, at the very least, the hypothesis is the identification of impairment as it relates to function. Let's take our individual who can't walk. So if we go back up, this patient comes in, you ask them, well, what are you having problems with? Tell me why you're here. What can't you do? Well, I'm really having difficulty walking. Okay, tell me more about that. And begin to describe it. You start to formulate your examination strategy off of that. Begin to conduct an examination. And as you conduct your examination, you're gathering some impairment data. So for example, what you'll learn this semester in terms of gathering impairment data, range of motion. Is there a limitation in ankle range of motion, knee range of motion, muscle strength? Are they having a limitation in terms of producing torque around a joint? So for example, are their vasti muscles weak? Is the gastroc muscle weak? Is the soleus weak? Okay. You will measure those muscles. You will measure range of motion. You will measure the amount of functional limitation they're having in their walking, and you will put those together. So an example of a hypothesis for this existing problem of walking could be patient has decreased vasti muscle strength, which causes dependency in walking. It's a generic hypothesis, but the statement connects the two together. Knee weakness, problem walking. Okay? That's a hypothesis for existing problems. Now, the other category, as we talked about, is so the anticipated problems, we identify a rationale. Now, we'll talk about in a moment why it's just a rationale. Now, I mentioned earlier that a patient may come in and identify an anticipated problem. I'm afraid I'm going to lose my job. The reality is, or more realistic, it's you, the therapist, that's likely going to identify an anticipated problem, what they are at risk for in the future. Most patients come in to see you because they have a problem now, something existing. They're focused on that and less so about the future. Okay. But still, so whether it's PIP generated or MPIP generated, we need to look at the anticipated problem. And so we develop a rationale. And what we're trying to do, or what we need to do in this rationale, is justify why management of this patient is important, because what we're essentially doing is arguing that we need to do this intervention to prevent this problem from arising. So the most, I'd say the most common, let me think of a good common example. Let's stick with our walking. So if we take our patient who's walking and they're having difficulty walking, okay, So the patient's having difficulty walking. What you might anticipate as a problem is future loss of balance because they're having difficulty walking, therefore they're less active, therefore they're going to be weaker, therefore they're more at risk for falls when they do need to move. Okay? So typically you as a therapist are one that are putting the pieces together related to an anticipated problem. Okay? The other way that anticipated problems are often looked at or described as are risk factors. What is the patient at risk for in the future? So I would say commonly patients who have injuries or are less active are at risk for other health conditions because of their inactivity. Right? Now, I'll say one last thing related to these two examples of hypotheses, and then we'll pause and move on to the second page of part one. The reason why this separation between these two types of diagnoses, one for existing problems and one for anticipated problems, is so important is because it highlights two aspects of what we do in terms of plan of care. One that's more common, more traditional, more thought of. The other less so traditionally, but certainly at the forefront of healthcare today. So for existing problems, we are managing what's happening, what's in front of us or what's in front of the patient right then and there. We're treating them. We're fixing something. We're changing something that's a problem right then and there. Can't walk, have weakness, design a plan of care to address that hypothesis and eliminate the problem, which is no more problem in walking. Okay? So someone comes in for treatment. Anticipated problems are geared more towards, we could say, 21st century healthcare, where we're spending more and more time developing health and wellness programs to prevent existing problems from popping up. And PTs, along with other healthcare professionals, have a much greater role in this aspect of healthcare today. And you won't spend a lot of time, if any time this semester, learning about that. You will later on in the curriculum. But that's why I think this category of problem, anticipated problem, is so important, because it highlights that while a patient may come to you and it's obvious what their existing problem is, you as a therapist really have a responsibility to look at what else they're at risk for. What are their other anticipated problems? And you have a responsibility to justify managing that patient to prevent that anticipated problem from ever occurring, to reduce their risk factors. Okay? And that's where health and wellness comes in. That's where patient education comes in. Okay? All right, so let's review before we stop. I'm going to make this page viewable. Oops. All right. So our first page essentially takes us through three aspects of patient-client management. The PT exam, that is collecting data, formulating examination strategy. Then the evaluation. Evaluation is giving meaning to data. And then finally the diagnosis. We have two examples of diagnoses. One for existing problems, generating a hypothesis, and one for anticipated problems, identifying a rationale. Right? So patient walks in, you start to gather initial data. You've got 4 examples of things you gather data on. You focus right away on what's most important to the patient. Why are they there? Tell me what you're having a problem with. Tell me what you can't do. You listen, you take some notes, should be in the context of their own words, what functional limitations or disabilities they're having. And you start to conduct your physical exam and ask additional questions based on what they say. Along the way, you're going to identify some other things they're not picking up on, but you see could be a problem. Now, these problems, whether PIPs or MPIPs, start to fall into one of two categories. Either they're right there in front of you, existing, or you anticipate them as risk factors. Okay. So what I would encourage you to do now, before you move on to this second page of part 2, where we refine the list, I would encourage you to go up and make sure that you have read through, starting here, the overview, and then get through part 1 in terms of collecting initial data. And then I'm going to pass these figures here. Generating a PIP list, formulating your exam strategy, conducting and analyzing data, NPIPs, and then generating your hypotheses. So I would read all the way up through the middle part of page 464 before you move on to essentially this third snippet, this third lecture. Make sure that you have a good understanding of this first page as they describe it in their own words. These 7 or so boxes. Okay? All right, we're going to stop here, and then I will pick up with refining the problem list. So we just finished in coming up with our hypotheses. In doing so, we need to refine our problem list. If we think about the number of problems that the patient may have identified, and it could be 3 or 4. Again, we're not discounting any particular problem right from the beginning. So they could have a list, and then we're identifying things. What we need to do is to be successful is we need to prioritize. We need to refine the list. Now, what's most important about this box, and you see a lot of text in there, and I'll point out that last sentence. Refining the problem list needs to be done in collaboration with the patient and or patient family, so that there's complete transparency and understanding of what you're going to focus on moving forward as you begin to establish a plan of care for the patient. So refining the problem list is not you sitting down at the end of the day and saying, well, I think we're going to focus on walking. I'm not concerned about their balance, even though they said something. I don't think this, or I don't think this is important. We're going to do this. What could also happen, and this is a slightly different example, but it's very possible and can occur. Oftentimes, therapists will focus on things that they're most comfortable with. So the problems that are listed, whether patient identified or non-patient identified, there might be 1 or 2 things that are in there on that list when the therapist looks at the diagnoses and the potential plan of care. They get excited about those things because they see themselves as an expert. Meanwhile, maybe they're not the most important problems. Maybe it's something else, to the point where someone requires a referral elsewhere. So at the top of this box, a very important step, which represents another good example where this approach is patient-centered, is that as you, prior to developing a final plan of care, you're refining your list, and you're doing that in collaboration with the patient. Okay. Next, we need to establish goals. So I'm not going to read through this box. You can read through it. But goals must be at the level of function. Now, what you'll see here as we talk through this is I'll have some graphics that will pop up that will show some examples of goals. But goals need to be at the level of function, and there will be a lot of discussion about goals, not so much maybe this semester, but as we move through the curriculum, this will come up again and again. And let me just briefly take you through verbally how goals should be structured versus how they shouldn't be structured. So if a goal is going to be functional, I need a long-term goal and then perhaps one or two short-term goals leading up to that long-term goal. So let's say my long-term goal for walking function is patients should be independent without assistive device, walking 1,000 feet 3 times with 1 minute rest in between. Okay. There's quite a bit there's quite a few variables in there that we can measure. And let's say I set that goal that we will accomplish that goal within 3 weeks. The way my short-term goals should be organized should be at that same level. My first one might be patient will walk with walker 50 feet times 2 times with 5-minute rests in between. Then the next goal after that might be patient will walk 200 feet times 3 times with 90-second rest in between using a small-based quad cane. What you notice about those 3 examples is that what's important about writing goals is that if I reach the first goal, I know I'm getting closer to the second one. Now, the other approach to goals, which you will probably be exposed to, which don't fit with this model, and I'll explain why, is that people write long-term goals as function and short-term goals as impairment. Now, if we scroll back up, you notice that hypotheses are the causal relationship between impairments and function. If I'm writing goals whereby the short-term goals are impairment and the long-term goals are function, then I'm essentially embedding my hypotheses within my goals. And the problem with that is, what if I am wrong with my hypothesis? I might think that quad weakness is causing the walking dysfunction. So I write my short-term goal to improve manual muscle strength to 5 out of 5 on the right vast thigh muscles. The long-term goal is that distance I described with no assistive device, minimal amount of rest, times 3 different trials of walking. Well, if my hypothesis is wrong, they might improve their muscle strength, but if someone comes to you and say, are they getting close to reaching their goals? If my hypothesis is wrong, you could be giving wrong information. You might say yes, but you're basing it off your hypothesis. And you don't know if your hypothesis is right. As opposed to, if you were measuring their accomplishment of walking consistently, then if they walk a certain distance with a certain assistive device, with a certain amount of rest, with a certain number of trials, and you use those same variables throughout over time, then you know that they're getting closer to their goals. Okay? So, refine the list, then establish goals. Now, the next few pieces I'm not going to spend a lot of time on. It's getting a little bit more advanced, but I'm just going to quickly highlight them, and then that will be it in terms of talking about part 1 of the model. Once we've established goals, we need to establish what you see here as testing and predictive criteria. We have testing criteria, which is related to our existing problem, and predictive criteria, which is related to our anticipated problem. Now, all you need to understand right now, and I'll direct you to the reading, is that testing criteria are used for us to test our hypothesis. We establish testing criteria to see if we are correct about our hypothesis. We establish predictive criteria to see if we are right about our rationale and the behavioral alterations we said we need to make. Okay. That's all you need to understand right now. And I'm going to use predictive criteria is a little bit more complicated, so I'm going to use testing criteria as an example. An example of establishing testing criteria to test your hypothesis would be you writing or documenting, and it doesn't really matter where right now. We're more just focused on understanding the concept. You documenting that in order to eliminate the problem, my testing criteria is 3 out of 5 muscle strength on the right vasti muscles. And what you're saying by that, you will later go back and measure, do manual muscle testing on the right vasti. What you're saying by saying 3 out of 5 is that if you measure them and they're 3 out of 5, you would expect that the walking problem has disappeared. That's the level of performance in the muscle that you think they need in order to eliminate the problem. So it's a criteria, it's a metric used to test your hypothesis. Now, just real quickly, just to scroll down, and we're not going to spend any time on it right now, but where these testing and predictive criteria come into play is in part 2, where we want to actually create our own evidence and determine whether we were successful or not. And if we weren't, why weren't we? Okay? All right. So what I want you to understand right now related to testing and predictive criteria are the definitions. They're used to assess whether our hypotheses or our rationales were correct. Okay? What I would encourage you to do is, I'm going to scroll down, but they give a nice description. I'm going to scroll a little bit quick here. So starting at the top of page 467, they give a good description of establishing testing criteria and then a good description of establishing predictive criteria. You really won't get any practice at this during this semester, and probably not so much, maybe a little bit next semester. But it is important to remember, because as you will hear beginning this semester and throughout the curriculum, we are going to focus, try to get you to focus on making evidence-based decisions. And so part of that is you establishing your own evidence. And by utilizing testing criteria and predictive criteria, you can later go back and determine whether you were right or wrong. The last 4 steps, relatively straightforward in terms of the stepwise process. We're going to assess our testing and predictive criteria, make a plan to assess the status of our problems and our goals. So we're going through this reassessment process. We begin to plan our actual treatment, our intervention strategies based on hypotheses and rationales or anticipated problems. And then we begin to plan our tactics and then implement tactics. Now, real quickly, and there's a good description in your text, so please take a look. I want to define strategies versus tactics. These are the interventions. A strategy might be exercise. The tactics is the actual prescription, the intensity, the frequency, and the duration of that exercise. Okay? So strategy is a little bit more general. Tactics is very specific. So that's why strategy comes first. Plan a strategy. I need to do therapeutic exercise. Plan tactics. Okay. What kind of exercise am I going to do? How long do they do it? How many reps? What's the intensity? What's the frequency? Right? Okay. So that is all of part one. We scroll back up. Again, reinforce. We're patient-centered approach, starting with patient-identified problems. We move through our exam. We create diagnoses and rationales related to current existing problems and anticipated problems. We need to refine our list with the patient. We need to establish goals at the level of function. We need to establish criteria so that we can look back to see whether we were right or wrong in terms of our hypotheses and our rationale. And then we develop plans to reassess this process. We begin to plan strategies and implement, or plan tactics and then implement tactics. Okay. Now the last piece that you've seen here, and I sort of mentioned but I didn't point or reference in the diagram. If we scroll back up to the top here, you notice throughout this model, part one of this model, we see consultation is if needed during formulation exam strategy, consultation if needed relative to generating a hypothesis, referral if needed, refining the problem list, consultation. Okay. What I want you to understand right now is from the very beginning, from initially collecting data at the top, you will learn to determine whether you need to refer a patient out, meaning it's an emergency situation perhaps, or another healthcare practitioner is better skilled or is more appropriate based on the information you've collected. Okay. You could refer to another PT, or you could just need to consult with a physician, with a nurse, or a PT. Okay. So what I want you to know right now is while you see these arrows in these small boxes throughout this model, really consultation and referral can occur throughout management of the client, the patient. They draw them in specific places. I don't think that's necessarily that important. What you need to understand is that it can occur throughout this process. Now, the last thing I'll say, and then this will be then that will be it. The last of these three lectures. Right now, we are going to emphasize this part one in this linear process. Start with collecting initial data, moving all the way through to implementing tactics. Okay, it's linear. Step one, step two, step three, etc. We do one, then the other. The reality is, or what we're shooting for, or what you would observe if you walked into a clinic, is that all these boxes are organized in a non-linear fashion. Many of these things occur at the same time. And the more experienced therapist is learning how to gather the information they need while also determining whether they need to intervene or consult, determining what problems along with the patient are important. They're doing all of this together. It's layered on top of each other. It's non-linear. It's circular. We can organize it various ways. And you will see in the fall semester when we follow back up with this, I will give you some additional notes and guide you through some different ways to organize this, that it's very much non-linear. We don't need you to be non-linear right now. We need you to be linear. We want you to understand each of these steps. Which comes first, which comes second, what box falls between two other boxes. We need you to retain and understand these steps and what they mean and why they're important. As you gain more experience, as you go through more case scenarios, as you become more comfortable with some of your initial skills in terms of assessing the musculoskeletal system, range of motion, joint integrity, you will begin to understand how these boxes can be interchanged, layered on top of each other, turned into a different shape, like a circle. Okay. Nonlinear. Right now, we're going to stay linear. Okay, so that concludes the last of 3 lectures related to part 1. Again, I would really encourage you to look through a couple times this entire paper. I've highlighted some areas that I think are important related to part 1, but really what you need to do is spend some time reading through the entire paper, listening to the lectures, and going back to the paper. Okay, take notes, whatever you need to do. I will set up a OneNote notebook for 731 that highlights some of these things to continue to reinforce some of the same concepts. But right now, within the first week or so, what you really need to do is just become very familiar with this paper. Okay. If you have any questions, I'll create a discussion forum on the 731 Moodle page where I can answer questions that people have. And of course, you're certainly welcome to come see me in my office if you have specific questions about something in the paper or something I said. And of course, certainly as you're working through material content in 731, certainly asking questions of Dr. Washmuth, Dr. Bowens, Dr. Lane, Dr. Dunn, or anyone else that happens to visit that course is more than appropriate. Very good. Well, thank you very much. And again, please don't hesitate to come find me if you have specific questions.